There we go. So good afternoon and welcome everybody to our most recent Lunch and Learn webinar from Public Health. So today we've got a great presentation. I'm joined by trying to find all of your full names, Dr. Mohammed Hossain, who's the Principal Investigator and Senior Lecturer at Birmingham City University. And I'm also joined by Bhawna Solanki, who is the Project Lead and Senior Lecturer also at Birmingham City University. We partnered with the university last year to conduct a piece of research on NHS Health Checks in diverse communities in Birmingham. And they're both here to talk to you today about the research itself and answer any questions. Now, there are some key recommendations from this report that have been taken forward by the council that if you would like any more questions on what the activity happening is, please either contact myself or Russell. We can put the relevant information in the chat. This is focused purely on the research side of it, so the first phase. So I'll hand over to Bhawna as be presenting for the majority of today.
Okay, thank you. Hello, everybody. I'm going to switch my camera off and then put the slides on presenter mode. So just bear with me. Okay, can you see the slides on presenter mode now?
Yes.
Great. Thank you. Thanks for confirming, Jordan. Okay, so the NHS Health Checks Birmingham City Council project. We're going to talk about the project. Dr. Mohammed Hossain, who is the principal investigator, is also here, and both of us are happy to take questions at the end of the presentation. So to begin, the public health team at Birmingham City University worked very closely with Birmingham City Council to produce the report on the NHS Health Checks research. So we have a team of multidisciplinary academics, and they actually reflect a commitment to addressing health inequalities through research. So it was a team effort in taking this research forward. And the report actually evaluates the NHS Health Check programme using a participatory research. We could not have gone forward without the help of community organisations who actually conducted the focus groups. So this presentation summarises the key findings, statistical insights, thematic analysis, and then we end with recommendations, which I'm so glad that Jordan has already shared with us that some of those are being taken forward. It's really pleasing to hear that. So just to give you a bit of a brief background, the NHS Health Check programme has been ongoing since 2009, and it might have, in small parts of the UK, might already have been ongoing before that. But there's increasing evidence that the uptake of the NHS Health Checks is low across diverse population groups, especially for racially marginalised communities. And this actually contradicts the goal of reducing health inequalities. So, for example, studies back in 2016 were conducted, and these already informed us that there was high uptake if outreach services were tailored to consider people's background and culture. And we also knew that uptake was low in any other white background communities and Black African communities as well. So looking at it from a Birmingham perspective, we all know that over half of Birmingham's population is from the global majority community, highlighting its rich ethnic diversity. So 88% of Birmingham wards face higher deprivation than England's average. And so we see worsening health inequalities in Birmingham. Cardiovascular disease rates are 3 times higher in deprived areas and elevated with diabetes and obesity levels as well. So there is a need for preventative health care, and targeted programs like the NHS Health Checks are so vital in reducing these health risks and improving community well-being. So the Birmingham City Council's goal is to improve access to preventative health care contribute to long-term health and well-being of younger residents, and help older residents maintain their health and independence. And we're all working towards reducing differences in life and health expectancy between communities. So in terms of the aim of the project, we wanted to explore barriers and facilitators to adopt NHS health checks amongst different ethnic communities in Birmingham. So what we wanted to do was assess awareness and knowledge and understanding in terms of people's perception. What were the purpose of the NHS health checks? What were the benefits? What were the eligibility criteria? We wanted to explore participants' experiences and what their expectations were around whether they could access NHS health checks easily. What about the quality? What about the delivery of the checks themselves? Were there any barriers for people who were invited? Are there any areas for improvement? So we wanted to look at the full customer journey. I won't call it a patient journey because some people invited for NHS health checks may not have any issues. So the full customer journey from awareness to follow-up care. What were the challenges? Are there any opportunities to enhance user experience, increase uptake? And we focused on understanding community-specific needs, addressing language barriers. And what we wanted to do was see if services could be tailored to foster trust and inclusivity. We also wanted to gather NHS staff perspectives. These are frontline staff who are delivering health checks, and identify if there were any training needs or any strategies to improve cultural competency, operational efficiency, even engagement with diverse populations. So in terms of the study aim, we aim to explore barriers and facilitators to NHS health checks amongst ethnic communities in Birmingham. We adopted a participatory action research and co-production approach, which involved community organisations as focus group providers themselves. So in terms of the sample, 22 focus groups were held. This included 193 participants, and we ensured diverse representation across ethnicities, genders, and ages. And we used framework analysis to interpret qualitative data and identify key themes and actionable insights. So in terms of the research, participatory action research and co-production, community-led focus groups, there were strengths for this project. There were collaborative roles and responsibilities during the lifespan of this project, and we wanted to build trust and strengthen relationships and work towards social action throughout the research. So the community groups and focus group providers that were involved were the Chinese Community Centre, Community Connections, Desi Diabetes, DOR Romanian Diaspora, Mindsci Development Saheli, SOS Education Organisation, the Revival City Church, Birmingham. And we looked at double-layered sampling. So the first layer was around ethnicity, participants joining from different global majority groups in Birmingham. And the second layer was looking at gender and age range. So in terms of designing the focus groups, we wanted to ensure that the methodology was suitable for this project. We wanted to make sure that discussions were within those research goals. And so we established focus group objectives. We wanted to ensure that the questions were crafted to elicit rich discussions, and we wanted to make sure that there were guidelines for each of the focus groups so that we would have constructive talk and ethical behaviour. There were detailed conversations around each topic, and we also wanted to support focus group providers in dealing with different group contexts. And so staff were paired with each of the community organisations if they needed any support and help in running focus groups or preparing for focus groups. So the discussions were around exploring issues to inform and improve current provision, and also look at future commissioning of health checks, NHS health checks. Qualitative research technique was adopted, and we ensured that participants were facilitated so that they could freely express their thoughts and opinions about the experience of the NHS health checks. So in terms of the focus group discussions, community-based organisations ran these, facilitated them, and a total, as mentioned before, were 22 focus group discussions held. 193 people took part. Out of these, 13 were NHS health professionals. So we also got some frontline views on possible gaps. And 2 focus group discussions were held with the NHS staff. From the 2021 census, the focus group discussion members were from Pakistani background, Indian, Bangladeshi, Black Caribbean backgrounds, Arab, White British, Chinese, Somali, Nigerian, Ghanaian, and people with mixed backgrounds as well. So this is kind of like a snapshot of data, and when you read the report, you will be able to see detailed data. But already mentioned, 193 participants were included, out of which 13 were NHS health professionals. Now, out of the 180 participants, 153 participants were of eligible age range of 40 to 74 years to have an NHS health check. And 45 people were reported as having attended and having had an NHS health check. So all of the 10 global majority groups were represented, and the average age range was around 52.1 years. And gender distribution actually varied across groups. So, for example, Chinese and Nigerian groups showed higher proportion of females and female participants. And in fact, it also showed that the uptake was higher in these 2 groups, but uptake was low in the Arab and white British men groups. So the themes from the focus group were around cultural sensitivity. We'll explore these a little bit in detail in the recommendations that's coming up in the next slides. But language was of particular interest, mistrust in the NHS, access such as inflexible appointments, and people were expecting structured follow-up plans to support continuity of care. So those were the key themes that actually arose from the focus group discussions. So if we start then to look at recommendations, then communication strategies could be developed. So, for example, we could consider translating invitation letters and brochures and instructions. So some participants said social media and messaging platforms like WhatsApp could be utilized. Consider a telephone call, but ensure that when the call is made, it's made from or by a person who speaks the language. And outreach tended to engage a more diverse audience. There were suggestions around short and engaging videos that may be informative to different communities. And there was definitely the sign coming from community organizations that they wanted to work together to ensure that people were taking the NHS health checks. So, for example, a Somali respondent said, if the imam at the mosque talks about it, then people will listen and take it more seriously. So location and accessibility was another key issue. So, for example, a Pakistani respondent said, if the health checks are in place or took place in a community centre or a place that they were familiar with, then it would feel less formal and more friendly. So the preferences were towards community settings like mosques, church, temples, community centres, schools. But there were also logistical challenges like mobility issues and issues around having a certain degree of trust and security. So community venues would feel less formal, perhaps more friendly. There was a mention around appointment availability. For example, Nigerian respondent said evening and Saturday appointments would make it so much easier for people like him who work long hours. And so the recommendation could be to consider community walk-in clinics. People also said that they like the traditional method of booking appointments by walking into a surgery. And also living in the digital age, they felt that online appointment bookings would help, but consider multilingual websites as well. So we mentioned language support as a theme that came across, and participants mentioned language support, but this support could be offered at every level. So, for example, a Somali respondent said it would make the person feel less shy and more assured if there was somebody who was speaking their language. So there is the options of interpreter services, but I know that these are scarce. So a Chinese respondent actually said pictures and diagrams are a great help for people who don't read. So perhaps use visual aids to provide summaries, translate written material, and maybe consider training healthcare workers in cultural and linguistic competency. So cultural competency came up as a theme, and here, so for example, one Pakistani respondent said it's so important for her to see a nurse who's a woman and comes from her culture and believes in what they do. So it was around acknowledging culture and religion and to be treated with more courtesy and dignity. Perhaps consider integration of gender perspectives into service provision. Offer culturally appropriate guidance on nutrition and physical activity and other lifestyle choices. For example, a Nigerian respondent said what's helpful is not being told to eat things that they weren't familiar with and perhaps didn't have the capacity to purchase. So it's about creating an environment where patients felt safe and a safe space to share their issues without the fear of being judged. And just on a positive note, a Caribbean respondent actually said the nurse was so kind and didn't judge, and that made a lot of difference to her whole experience of having an NHS health check. So, considering the broader impact of optimizing NHS health checks, it's about reducing disparities by targeting diverse population needs effectively and building trust, ensuring there's cultural sensitive approaches that improve healthcare uptake. And it's about promoting early detection and prevention, leading to better health, but also less system burden. So we could have the programme serving as a blueprint for inclusive, equitable public health interventions nationwide. So that is a quick summary of the report, the NHS Health Checks focus group report actually highlights the barriers and facilitators to service uptake. It shows recommendations that can be implemented, and good to hear that some of the recommendations are already being taken on board and acted upon. And there's also scope for ongoing research to enhance accessibility and effectiveness of health programs. So Dr. Mohammed Hossain, who's the principal investigator for this research, and myself, we're here and very happy to answer any questions, but feel free to contact us as well if you want to after this session. So I promise not to use ChatGPT to try and find answers. But yeah, if you've got any questions, feel free to ask. And before we open the platform for asking questions, I just wanted to say a huge thank you to everyone, Birmingham City Council, for having that trust in us to lead this research, all community organisations without whom we could not have got to the final stages, and Birmingham City University staff for supporting the research project throughout. Everyone for listening. Your thoughts and views are really valuable, so please do ask us any questions. Thank you so much for your attention and dedication to advancing public health equity across communities. So that's the end of the presentation. I'll get back into Teams and open my camera, so feel free to ask questions if there are any.
There's one hand up for a question.
Okay, yes.
My name is Alfred Bochum. Just completed public health MPH in Wolverhampton University. One of the presentation, one of the key points that I picked up from what you said was in terms of from cultural perspective, people wanting certain kind of services to suit their cultural needs, and from the frontline perspective, looking at the logistics that is currently available, is it our recommendation? Why I wanted to just push the question to the recommendation, because looking at it, it's not feasible to be able to, for example, I work in ITU. In ITU, you have specialities with special knowledge on certain things. So you will have a patient, let's say is from a Nigerian Muslim, a female that probably will require a female to look after her, but the possibility is non-existent. You don't have a majority of those people in those culture of a lot of female that have that ability in that knowledge skill set to be able to deal with that. So when it comes to applying that, is it possible to reverse it in terms of the recommendation to try and educate the community for them to have a realistic idea of the structure that we have in place? Because sometimes it becomes quite frustrating if you're on the front line and people come and they are demanding certain aspect of care, but it's non-existent based on clinical skill set. So it's just like a question or just a recommendation. Can we flip it around, trying to educate the public? This is what we have in place, because sometimes it's quite frustrating when you are a health professional and trying to do your best, but based on what they are recommending or what they need or what they think that is supposed to be is non-existent. They become agitated and kind of they are not kind of I will say well liaising with the health professionals appropriately. That's one to know. Is there a way that we can actually go back in some sort of recommendation, trying to educate the public in that view that this is what the NHS is, or this is what we have in place? Yes, we will accommodate you if we can, but there is 9 out of 10 chances that it will not be possible based on the mixed skill set of people that are working around the environment. So therefore, people should be more accommodating. And I think if we go through the community leaders trying to channel this education through, I think we will be able to hide some of those issues. Thank you very much.
Mohammed, shall I start with an answer to that, if that's okay?
Please. Yes.
Okay.
Yes,
Yeah. So thank you for that. It's very relevant. You're right, and it takes us back to the age-old discussion around resources. You know, whether we have the resource bank to meet every community's need, and it's similar. I mean, I remember the discussions we had around interpreter capacity within the NHS, and it was the same. You know, how could we look at tailoring and meeting needs of diverse communities to ensure that the interpreter services were around. And it's the same thing here, you know, around cultural competency. And you gave an example of a Nigerian community, and especially females. Yeah, you're right. It's slow and steady. The steps are going to be slow and steady, and also it's about working with community organizations, working with communities, but at the same time ensuring that communities understand that it's not going to be an overnight solution. You know, it will take time, but actually highlighting that there is a need is the first step. And ensuring that we're working with community organizations and listening to community organizations is an important step, you know, towards progressing and ensuring that community needs are met. So thank you for that. I hope that answers your question.
Yes, can I add something to as well?
Thank you, it does.
Yeah. So that's a very interesting question. As the point is, you know, you mentioned that it's not feasible, you know, to expect so much from the, you know, service providers. That's why if you have read this report, you would see there's many participants. What they're wanting actually, they wanted to see something community venues where they can, you know, go and there, and also some of the participants which Bhawna highlighted, that they mentioned that trusted messengers from the community, for example, the imams or, you know, community leaders or faith leaders. So in order to an imam talk about NHS health checks, definitely they would need training on this, for example. So this might be the, you know, job for the policymakers or you know, the organization or, you know, providers like Birmingham City Council. They might, you know, gather them together and, you know, train them. Yeah. So this way, you know, they can get more trusted messengers from the community. And I think at the same time, this will reduce burden on NHS health staff, you know, talking about this and other things. So, and again, when they talk about local radio, WhatsApp groups and other things, so it's got to be all in, you know, the thinking about the, you know, putting things in more in the community than on the in the NHS, you know, venues or somewhere within the hospitals or GP practices. Yeah, but thank you. Yeah, that's really interesting. Well, this is, you know, our recommendation as well. So hopefully in the future, whether it's possible or not, it will be. Okay, thank you.
I think Jordan,
am I able to come in a little bit on that as well? And just to add on that, going back to the example of saying that we need to make the services more culturally competent, and the example you had of a Nigerian woman wanting someone from her cultural background to do the NHS Health Check. And we have looked at how we can implement kind of some aspects of the recommendations, even if, as you said, from like a resourcing point of view, it's not possible for us to guarantee that there'll be super specific staff that are able to deliver each health check, but how are we able to address parts of it? So, for example, we're currently looking at revising the invite letter to at least state what the gender of the clinician is likely going to be when you're booked on to an NHS health check, and how to get in touch if you would like to request a female specifically if you're given a male practitioner. Now, we're not saying that we'll be able to guarantee it every time, but if I remember correctly, Bhawna and Mohammed, that some of the feedback from the research was that people were then hesitant to even know they could contact, they would just ignore the letters in case there was, and they were being given a male practitioner. So we're at least trying to remove some of the barriers. It still may not be appropriate for everyone, but trying to kind of put some steps in place that work towards some of those recommendations.
Yeah, definitely. Thank you.
Thank you.
I think, is it Olatunde? Do you have a question?
Oh, I was just going to build on Mohammed's response and possibly add to what Jordan responded already. I think there are two sides to that response to the question from Alfred. The first side is that there is a need to build trust on both sides of the divide. Trust between the providers and trust within the community. As you would find in most relationships, usually when there is trust, it's very easy to overlook shortcomings. So I think that's the first side in that. And the other part regarding setting up the health checks would be to actually recruit for diversity. So if we are going to stage NHS health checks in communities where we know that it is predominantly Muslim, then it is culturally competent to resource the team with Muslims so that when people turn up, those kind of gap that Alfred talked about is less apparent, and the same will be true if we are going into communities, for example, where the English language competence is not very high, just for the sake of eradicating health inequality in the society, it makes a lot more sense to have multilingual people resourcing delivery of NHS health checks in those kind of environments.
Absolutely, yes. I think it's a good point made. And so perhaps the recruitment strategies need to acknowledge, diversity in staffing. Yeah, thank you, Olatunde. Is it Saba?
It is, yeah.
Yeah, hi Saba.
Hi. I just wondered how much exploration you have done into potentially using technology to bridge these gaps. I mean, we've not done any significant research, but literally today we undertake health checks by using a health kiosk. So rather than undertaking them by, a physical one-to-one person, it's undertaken effectively by what is effectively a machine. Now, we recently, only a month ago, installed a health station into Cambridge City Mosque. And today I found out that in just a month we've done 700 health checks in the mosque, and like 90% of them are with South Asian men, and that has just been astonishing for me. So I just wondered whether there had been any exploration into that, because certainly from what we're finding, I can recognise all of the kind of barriers in terms of wanting, cultural understanding, fear of judgment, all of that kind of thing. And what we're actually finding is, yes, it's not always possible to give someone in a physical sense the person that they want to speak to, but by undertaking these in a more technological way, it's breaking down those barriers, because it's not a white British male that is undertaking those health checks. Has anything been done in terms of looking at that?
I think the only comments that came from the research that I mentioned were, considering online appointments, considering multicultural websites. So no, I mean, Mohammed might correct me or add to it, but I don't think that was mentioned. However, it's so good to hear that you actually increased the uptake by having these kiosks. So are they expensive to run? I'm intrigued.
No, you'd be surprised. So we do all aspects of an NHS health check other than the phlebotomy, obviously, because that can't be done on a station, but we signpost to those opportunities. We had a public health authority do some independent research, and they suggested that it was about 6% of the cost of a standard health check, because it doesn't involve a person, which we know, can be a bulk of the cost. I can certainly share some information. You know, obviously this specific scenario we're only just still gathering information back from, but I'd love to share some information about some of the kind of insights that we're seeing, because we didn't necessarily start out from a position of health inequalities, but we're certainly finding that we're really generating some good results in that respect. So I just wondered whether, you know, that would be or whether it is something that you have also found. So it'd be good to maybe, yeah, potentially give you some insight into that.
Yeah, I think that would be really good. Jordan, I see her nodding, so I think she would probably be interested. But Russell, do you want to come in?
Thank you. Yes, Saba. Yeah, sorry. So I lead on the health checks in Birmingham City Council. It's certainly something we haven't looked into, and we've not been made aware that there's any technology out there, sort of that. So that it's really interesting to hear. And I think, like you say, if possible, if I can, we can make contact after this meeting, like, and talk about, obviously go into the details of how much it is, how much the kiosks were, because it's something obviously we can take forward for that. It's the only thing that sort of we was looking at technology wise. Well, saying going into communities with possibly using a sort of community van and going out and doing a health checks at sort of mosques and religious events. So if we can get some kiosks like that, because we are building into wellbeing zones in the local libraries, so every area will have a wellbeing zone. So possibly it's something we could fit into there, and we can put on signposts to that. So yeah, if we can take that further outside of it, so that would be really interesting to hear more on that.
Excellent, no problem.
Yeah. Thank you.
So Saba, could you put your email address or your details if you want to share them in the chat, so that Jordan and Russell have them in case they want to contact you for more information. Thank you. I think Mohammed, did you want to say something?
Yes, thank you. That's really interesting. Yeah, so I mean, the software or any electronics technology were not particularly discussed within the community participants group, apart from using automatic SMS services. But within the NHS health staffs, they mention about Ardents, which is, you know, as you know, there is the electronic templates where, you know, to make more NHS health checks done in, you know, promptly, quickly. But at the same time, there are pros and cons to using that, you know, that Ardents template, because, you know, coming from different diverse background, you know, it might not be, you know, one that might not fit everyone. So we need, you know, maybe, you know, culturally appropriate template. Maybe we need to, you know, prepare on something. I mean, you know, adapting from Ardents, which is quite, you know, for common for everyone. But that's a really good question. But as I mentioned, one of the practice manager during the NHS Health Checks focus group mentioned about technology Ardents. Yeah, thank you.
Thank you, Mohammed.
Thank you.
Russell?
So yeah, just to come in onto Mohammed's comment there for the Ardents templates, Birmingham and Solihull jointly work together, and we have created a new NHS Health Check template that's going to be across System 1 and the EMIS systems that we use in Birmingham. So it's already been implemented, and that's going live hopefully by the end of this month, start of November. So that's something, again, from your focus groups reports that we've already took part in, and we've worked with the ICB and CSU to create a new template, and that's going live, like I say, end of this month, start of November. So they won't be using the Ardents template anymore. It'll be using our own, and it will have all the local services at Birmingham and Solihull Commission, and like you say, it's culturally competent as well.
That's great. Thank you.
Great, thank you. Are there any other questions? I mean, it doesn't have to be towards us. It could be towards Jordan and Russell as well, because it's really good to hear that some of the recommendations have been put into action. So, is it Kafila?
Yeah. Hi.
Hi.
So I know Jordan really well. Hi. Hi, Bhawna. So I mean, so I work at the ICB, and we've been over the last sort of year, we've been doing a lot of health checks and community outreaching. So just similarly to what you've mentioned around the bus and a sort of a van, we've been working around cancer awareness, and as part of that initiative, we recognise that the only way we can get the community to engage is actually to put things on offer, like, for example, doing blood pressure checks. More recently, because of the demand that we had from the conversations that started coming out through the community, that they wanted, they were having challenges getting access to their GPs. And whilst, you know, colleagues will know this, you know, there's various offers where they can get some of the NHS health checks. They're not readily available for some of the population, and because access is a massive issue, it's not something that people typically know or are able to engage with. And we also recognise that you know, language and translation and disabilities, the barriers of that, the sheer volume of sort of queries that we had from different groups. So, for example, we did some work with the Chinese community and recognizing the different dialects, and looking at where people not even realizing that actually the Chinese community center was round the corner from where the bus was, and then signposting them into the community sort of settings and encourage them to get some further support. But essentially, I just think, I mean, resources are always an issue. So it's just a question to you guys, how do we work together in this space? Because we're already planning our next round of tours. And it's just one of those things, like, you know, we're potentially going to face some further cutbacks next year. And to keep this going, we know how successful it's been. So our level of engagement has increased, and we are having really good quality conversations. So just to give you an idea, we did around 1,600 health checks. And with that, we gave sort of an advice and guidance. We didn't necessarily suffer for those that are from primary care, not to scare you, we didn't refer people back to their GPs. We carried out the health checks, we did advice and guidance, and a lot of the times we were well supported. So if we were talking about smoking, diet, we had various organisations surrounding the bus that were then able to pick that up. We even worked with Aquarius. So I think the foundation's already there. We're aware of the areas that, you know, are really successful, where that uptake is. We're also collaborating. For example, we continue to have that partnership, and we've been really successful in continuing our community engagement. We haven't upset anybody yet. Well, that's sort of saying people are still happy to continue working alongside us. Because just mindful, obviously, with community organisations, resources are really limited. So we're trying not to ask too much of them, but we do sort of ask them to, if they can, share things on their social media pages, and we usually create it. But it's just, again, like, to avoid any duplication, just sharing our learning with you guys in this space. And then it would be great if we could talk about maybe the gaps where you know, if it's a case that we can't do this together, but if you're, you know, maybe it's a bit of a continuation. So if we are talking cancer screening and we're doing health checks, how do we kind of keep that communication in-house so we can sort of manage that and it's more succinct, and you know, it's a bit of a continuation, because at the moment people are asking us, when is the next bus tour happening? We just finished last month and it's not happening until April, but that's purely down to, you know, looking at the weather and the challenges of resources and the winter periods and things like that. So just to kind of mention all of that.
That's great. Thank you so much for sharing your experiences. Maybe Jordan or Russell, would you like to come in around the working together bit? If I don't want to put anybody on the spot.
Yeah, absolutely. Like Russell's already mentioned, we're already looking at vans and different ways to get the health checks out into different areas. And when we're like right in the kind of the process of how we actually make that tangible, we were already looking at hosting some sort of kind of sandbox working event, as we were in touch with Community Connections, and they really suggested getting everyone together to share learning. So we'll definitely make sure that we'll keep you in the loop, Kafila, because I think it'd be wasted if we don't share learnings with one another and what works and what doesn't.
And resources as well for you guys, if I just wanted to, like, you know, we're not being precious at all in this space. We really do want to, and if we can, you know, slip in further discussions. So just to make you aware, we were very lucky. We managed to do lipid tests, which is the cholesterol checks, and we trialed that, and now it's, you know, gone far and wide, and lots of people have been getting in touch to say, how does that work? Because they're very similar to flow tests, but actually working with a clinical team now, having that clinical structure, having the SOP in place for all of that, just to save you guys sitting on meetings and thinking about, you know, all this is what we might face. We've already done that. We've been on the road, and we did it without any idea or any clue what it would be like. So we did, you know, and we brought some of those community partners along with us, and we've been fortunate to continue that collaboration. So I'd be keen to share, and also like maybe think about that clinical support we can provide to you as well in this space.
Great, thank you. Mohammed?
Yeah, thank you, Munir, Kafila. That's really interesting. As you were talking about gaps, resources, and again, when you talk about duplication, I do not think there will be. I mean, we have a very limited scope for duplicate, because massive research needs to be done about NHS health checks. When you did a scoping review with the help of Jordan and David, we didn't find a lot of study out there already, you know, about NHS health checks. So, and when you did this by the help of Birmingham City Council, this NHS health checks, I've been receiving emails from Manchester, from Cambridge, that have you published your data? Can you share this data? So there are a lot of data, you know, needed for this study. So one of the things, gaps, which is we didn't go too deep into this, but you know, by looking into this, you can see that 180 community participants participated in our study. But one of the gap which I was thinking, which you didn't analyze, but you know, analyze out of the analysis, is the gender gaps within our, you know, participants. So out of 183, women are more. So, you know, doing research within ethnic minority groups, global majority group in the UK for many years, I've seen men are always ahead of women. Yeah, women are running a little bit behind. But for this project, you see the women are running ahead of men. The reason is I was trying to find out why is this. So out of 180, we have 97 female participants, 83 men. And when you do the NHS health checks, 26 out of 45, 26 female had NHS health checks, whereas men had only 19. So why is that? So I was thinking, is this something that are women really running faster? I mean, ahead of that. I think the reason is the availability of the slots. It perhaps the men were in the workplace at work when they did the focus groups, or when they, you know, at the NHS health checks. Maybe men are not available there at work. That's why some of the participants mentioned that whether NHS health check, you know, appointment slots could be in the evening or in the during the weekends. So that's what they're asking, whether it could be possible. So again, those, you know, whether you're talking about bar stores, yeah, it might be definitely it would help, you know, going to the participant rather than participant going to the services. So I was really thinking about why men are less within this study, you know. So it might be another gap in your, you know, project if you're doing in your research, maybe why men are running, you know. I don't know whether in your perspective if you have more men than women.
Just to give you an idea, we collected electronic data, so we did do surveys with the population. So 1,600 people, 2,500 that engaged outside, some that hadn't come on the bus and that had engaged outside, but we monitored that by an information bag. So if they took an information bag and a colleague was able to tally outside, those numbers were kept slightly different to those that actually came on the bus. We had a 60-40. So it was 60% women. However, we did see the men, and especially working with the Green Lane, where they had 2,000 people during Friday prayers. It was just targeting them and doing targeted work around them, and being mindful, you know, again, of the time that they had. So we tried our best to have many more people on a Friday, for example, when we were targeting men. And just to say, you know, it definitely made a difference doing it in the community settings and working with community partners. We saw a slightly less number of men coming through the Chinese Community Centre, but they have done another drive and they're going to do something separate because they talked about the taboo and, you know, again, like availability of that population. But we see all these as factors, and we know that essentially from speaking to the men that we did survey, they had talked about that comfortability again, like, you know, not really being comfortable talking about signs and symptoms. So we were looking at cancer and looking at screening, and not necessarily any other. It's down to the fact that a lot of them were talking about the fact that I only do this if my partner drags me, or I'll only do this if my family member puts pressure on me. There was a woman that came with like 3 or 4 family members, male family members, and she stood there and she was like, I'm not gonna let you get off until you get your blood pressure done and get this done and get that done. And we saw a lot of that in the community, especially when we were in Small Heath and in those sorts of areas. So I think it's just catching them at the right time in the right space and providing them that support. We did get feedback that there's not often a lot of male medics, which puts people off. So on the flip side, Jordan, when we're talking about females, males also in certain communities might feel reluctant. And I'm not limiting this. It could be men on a whole. We don't know. But we definitely saw a bit of a pattern. So if we had a male GP on, we had a wonderful response. And when our colleagues were sort of occupied, they were less likely to kind of stick around and go into more of a detailed conversation. But we did talk about prostate, and we did live examples using female clinicians. So just to tell you, it can't all be down to culture. And, you know, I think it's just creating a space, making people feel safe. Men have to feel safe as well. We forget that. So these are just some of the things. After seeing that sheer volume of people over the last 12 months, I don't think it can be captured in a succinct way. But, you know, looking at individuality, looking at personalized care, I think that if we do things more organically on a community basis, areas differ. If you just look at Solihull and, you know, an area in Birmingham, they're very different. They're not the same. So going to one area and then coming to another area. However, to emphasize, needs are always there.
Yeah. I actually agree that gender issues should be acknowledged for men and women. You made a really good point there, Kafila. Yeah, so thank you. And thanks for sharing, you know, the experience of your all the survey results and your observations. They all add, you know, to making that the big picture, the big jigsaw around how we can address health inequalities and improve our healthcare services. So yeah, thank you. Thank you.
Can I ask a question, please? I'm sorry. I think you did a large study, 2,500 survey. Are you publishing them, or just, I mean, the purpose of?
It's ongoing. So our work is about increasing screening. And this is what I'm saying. It didn't necessarily need to be an academic study because we were not intending. So when I spoke to my clinicians, we purposely intended not to make this an academic study. It was more about looking at interventions. So the data in itself is, if you think you've got how many minutes in a GP practice, how many minutes would you have in a public space? Even less. Because if people are seeing a lot of people lining up, they might get nervous, and those that with poorer mental health, that anxiety would not stick around. So I would say that it's at the moment, the information is used to drive our social media pages, to support conversations, and we know that's more beneficial in the long term. If we can say to you that these interventions are going to carry on, it's basically to focus on the fact that it is very popular. It's very much needed, and we need to just sustain that way. I think sometimes in academia, things can get lost in translation, because by the time the study's finished, things have changed. And it's a smaller sample. That's the only dilemma we have with, you know, if we're doing qualitative studies, you can only do small sampling. With things like this, these are live interventions. They're going to carry on. So you're more than welcome to come along and observe. You know, we've actually recently had the Shisha project. We've had the mental health project. We've had lots of colleagues, and, you know, Jordan will tell you, we're always talking. We're always looking at where we can link colleagues in to support us around this.
Lastly, I apologize. I'm asking too many questions before I know I'm aware of the time. So, I would like to get your, contact. For example, you mentioned about social media. The reason I'm saying, because, we are working on, publishing this study, everything. So, as I mentioned earlier, you mentioned also that we do not want to, reinvent the wheel. Yeah. So if you got something data with the, so it might be a really good idea for us to know what you are doing, so that when you work, when you submit this, and we can acknowledge your work also, or if something is really close, we can avoid that. So yeah, if you could please share your social media page or anything, then where we can get those data, please. As you said, you're not publishing them. It might be helpful for us, please. Thank you very much.
And just a question from me for Saba, who shared about the kiosks. Have you considered evaluating the effectiveness? I'm sure you've already sort of broken the ceiling in terms of statistics.
Absolutely, it's something that we definitely want to do. We've got a huge amount of data. So in the UK, I think we've now done a million health checks using the station, and about 300,000 of those were in the last year. I mean, we've kind of, our focus has been on just responding to everybody's needs, whereas we are now trying to kind of take stock and look at kind of research. But yeah, we would certainly be interested in seeing, the potential there. And, this call has been really kind of enlightening. I've loved hearing the stuff that Phila has been saying, and I've just been nodding along to loads of it. So that has been really insightful. But yeah, we are finding our feet in this space and want to do more. So certainly, if anyone wants to reach out and swap stories and share stories and see where we can make a difference, that would be really great.
Great, thank you. I think we've got conscious of time, but Chris, you've got a question? Chris Baggett? Do you have your hand up?
Hi, sorry.
Hello.
Just a quick question. I realise that health checks are a tool, and the real intervention is where risk is identified that something is actually done about it. And I just wondered, in your focus groups, you had a small number who had actually had a health check. Did they give you any data on what had happened as a result of the health check?
Mohammed, would you like to answer that?
We didn't get into their, the data. We just wanted to, find out their experience, their journey towards, but we didn't get, what data they got, they received after that. So we didn't ask, we didn't go too deep into the actual, and so we had 45 participants who had NHS Health Checks, but we didn't actually explore them, which is not.
Okay, thank you.
Thanks, Chris. Okay, any other questions? We've got 2 minutes left, Jordan.
What I'll do real quick is I'll stop the recording as well, just in case there's any questions in the last minute that don't want to be on the recording afterwards.
Thank you.